second presentation for this afternoon. Before we do so, just a few quick reminders for everyone. So we are trying to reduce our paper usage. So we're not got any hard copies of the timetables last night that we're handing out. If anyone would like a timetable though, we do have a number of printed copies, so please come see myself or Dylan if you'd like one for the week. And also certificates. So they're going to be emailed to you all at the end of the week. Please make sure that you have registered at the back of the room with myself or Dylan, just because that's how we get the attendance list. So certificates will be going out at the end of the week, and that's all through our e-learning portal. So hopefully you've all seen the email that's come through from Mesh. If you haven't received that email and it hasn't been diverted to your junk mail, we do have a bunch of bits of documents going around with a QR code. All you need to do is scan that code, put your details in, and then the team from Mesh will get you all registered and enrolled for the e-learning portal. That will stay open for another 2 months post the conference, so there's no need to rush into completing that one. The idea with the e-learning is purely for you guys just to work through at your own pace, at your own location. That's it for me for now. So I'm going to hand over to Ulrike Brandenburg, who's going to be talking about neonatal resus. So let's make her feel nice and welcome.
Good afternoon. Let's see whether, yeah, it works. Thank you for attending the talk on neonatal resuscitation. Despite the freezing temperature here in the room, so I really appreciate that you're still all here. Now, neonatal, by definition, is a newborn infant up to 28 days of life. I would like to focus in this talk really on the first few minutes of life, so please join me on the journey to the first few minutes after birth. Why is that? Because it's actually a time of really major transition. You have a little human being who's been really in water for the last 9 months or so, and then suddenly after birth needs to deal with breathing and transitioning to extrauterine life. So this is quite unique. And this is a situation you don't really have ever again throughout life. Some babies also have quite a bit of trouble, is that all right? Making this transition. So you probably know that the day you're born is actually the most likely day you die, except the day you die. So you can actually have lots of issues going on, and if you see the statistics in which was recently published from the Australian Institute of Health about how many babies need some help during that transition phase, you can see that in view of needing some oxygen therapy or suctioning, and in view of needing positive pressure ventilation, about 15% of all the babies, so more than 1 out of 10, will need some help to make this transition successfully and safely. Luckily, very, very few infants require what we call full resuscitation. But one of the really important things to consider is that really for this to happen, you want to get the first few minutes of helping those babies transition really right, because if you do, then it is less likely for a newborn infant to require full resuscitation. Now, being prepared is one of the major things really to accomplish when you attend neonatal resuscitation. So firstly, obviously, to anticipate that there is a need for resuscitation. So by you being here and hearing about neonatal resuscitation, that's a major step, even though you may not really experience this situation a lot. But I guess there's always this call to the pregnant woman who's about to give birth, and she delivers right in front of you when you reach the house, or the woman who comes with abdominal pain into ED, and by the time everyone tries to figure out what's wrong, she's delivering a baby, not knowing really how long she was pregnant for. Very important for that is that you have equipment you use, and you're really familiar with that equipment. That you have some standard procedures, such as the flowchart, which is published on the Australian Resuscitation Council, have that printed and laminated and really ready for use, because obviously, especially if those situations don't happen very often, you want to feel really familiar with what you're doing and how you're doing things and what you're doing these things with. One of the recommendations we have is that all the equipment you use in standardized kits, just because a lot of the equipment is something you wouldn't really use in adult medicine. They're also a lot smaller and often much harder to find if you want to kind of piece little bits and pieces together. Now, I promise I won't kind of get bored here with physiology, but I think it's really important that when we talk about transition after birth, that we talk about the major changes which occur after a baby is born, because knowing this will help you to do the right steps for the resuscitation at the right time, if that's required. Now, what you can see here is the fetal circulation. So the circulation of the blood before birth. And you can see that there is an intact placenta. From that placenta, obviously the baby, the fetus, gets all the oxygenated blood here in red. And also in that is like all the nutrition it needs for the development. And that blood is going into the fetal heart. And from there, with a few shunts, it is able to be distributed around the body. So the first shunt is between the right atrium, where the blood reaches first, and the left atrium is the foramen ovale, which is like a little flap, because when the blood goes into the right atrium and collects there with quite a fair bit of pressure, it pushes this flap open. The next shunt you have when the blood goes out through the right ventricle into the pulmonary artery and goes into the lungs. Now, there is a little bit of blood going into the lungs, but not very much, because the lungs are not used for oxygenation in the fetus, obviously. So most of the blood actually shunts after the baby, after the blood has left the pulmonary artery. Yeah, it is not working. That's fine. Into the aorta. So these shunts are really important when a baby is in a fetus. But once a baby is born, the circulation changes into the neonatal or post-birth or adult circulation. Now think about what the very first change is when a baby is born to make that circulation change. Does anyone have any idea? The first thing which needs to happen for this circulation to change from the fetal into the neonatal circulation. Now, the very, very first change which needs to happen is actually that the baby takes a breath. That is really important, because when that happens, the lungs expand, and with the expansion of the lungs, all those little alveoli in the lungs expand, and the capillaries, the blood vessels around those alveoli suddenly get much, much wider and have a much higher capacity to take blood. The resistance drops. And with that drop in resistance, the pulmonary pressure drops significantly. And when that happens, we have a pressure change on the lung side, so the right pressure, the right-sided pressure of the circulation suddenly drops, and the left-sided pressure is much higher, like in an adult, right? So when that happens, that little foramen ovale, that flap closes, because now the pressure in the left atrium is much higher than in the right atrium. And also, the shunting from the pulmonary artery into the aorta changes around, so suddenly the shunt is from the aorta into the pulmonary artery, and with that higher oxygenated blood going that way, the ductus arteriosus closes. So it is very important to know that this is the very, very first step to a successful transition, because that tells you what? That the first important thing to do for this little baby to get to a successful transition is to take a breath. And if the baby can't take a breath, then we have to do it for them. The clamping of or the cutting of the cord, or clamping of the cord, has really nothing to do with changing the transition, changing the circulation from fetal to neonatal. The clamping of the cord is actually something which we shouldn't be doing, because the intact cord can be used in our favor if there is a delay in transition, if the baby doesn't take a breath immediately after birth. Because, see, the placenta has given the baby the circulation and all the needed oxygen and all the nutrients throughout the pregnancy. So why should that be any different just a few seconds after birth? It is not. Unless in very rare situations where you have something like a placental abruption. But generally, the placenta will continue to support that baby even if the baby doesn't take a breath immediately. It is advisable that all your steps of resuscitation of that newborn baby is actually done while the cord is not clamped, while that cord is still intact, to give the baby the support it needs until it has taken its first breath, or until we were able to ventilate the baby's lungs. There is really good evidence behind this in regards to morbidity and mortality for newborn infants. It is very beneficial for them to have the cord intact. So there is a recommendation in the neonatal resuscitation guidelines not to clamp the cord for at least the first minute of life in term infants. In preterm infants, it is actually even more important to do the first few steps of resuscitation and stabilization before the cord is clamped, because for preterm infant, the effect of having that support within the first minute of life is even greater. And you can see here two pictures of a cord. One is directly after birth, and the other is about 15 minutes later, where you can see that, it's a really sort of empty cord now. And this is what physiologically happens if the placenta is still working well. There is a lot of blood pumped over through to the baby. after birth, and that extra blood volume is helping, especially a preterm baby, to have a more stable blood pressure, to have a bit more time to take its first breath, and to have more red cells, giving it a better outlook for the later life. So the first few steps of resuscitation really should happen while the cord is still intact. And we are going to start with the assessment of the baby. And that's really important because it'll tell you after a few seconds whether a baby does need any resuscitation or not, whether that baby belongs to those 15% needing extra help or not. Why is this important? Well, because we're not going to take a newborn baby away from its mother to sort of a table to, look at it, which is sort of maybe something we would do. And in other circumstances, if a patient comes to ED, you set them on a couch and say, oh, okay, so let me assess you properly. But you don't really do that with a birth if everything is going well, right? So what you do with a baby who's well, you put it on the mum's skin on the mum's abdomen and let them be together, and that's really important. But how do you decide which baby you do that with and which baby will need extra help? There's three major questions you want to ask yourself. One is, do you know whether the baby is term or preterm? Because a preterm baby generally will need some attention, especially if it is very premature, and you need to pay a lot of attention to this baby's breathing and other functions. The second question is whether the baby has a really good tone. Now, the muscle tone is something which is very easy to observe when a baby is born, because when a baby is born and in a good condition, those babies go back into that fetal position. They kind of, they bend their arms and legs, and they're in that fetal position. If they do that, the muscle tone is good. If you have a baby who's born and the arms and legs are hanging just away like this, and the baby's very floppy, this is a baby with a poor muscle tone. This baby may need your proper attention. The second thing is whether the baby is breathing or crying. Again, that's really important. Not all the babies cry. That only happens in movies. A lot of babies don't cry, all right? They just start breathing and open their lungs. Crying is often good because, it gives them this really good strength and negative pressure to actually get the lungs well open. But they don't have to do that. But it's really important if a baby does not breathe, remember that circulation, it will not change. You've got to make this baby breathe. That's really, really important. And these things, those assessment questions, and to make sure this baby is breathing or make this baby breathe is really important to happen in the first minute of life. One of the major steps, and you probably know that if you've been at a birth before, is to stimulate the baby. If you have a baby who hasn't taken a breath because it's been in primary apnea after birth, when you stimulate the baby will start breathing, and then from there on, the transition can happen successfully. In movies, that's kind of putting the babies upside down and slapping it on the back. Like, we don't do that anymore, okay? No slapping. So what we do is really with a towel, just rubbing the baby's back, rubbing the foot. Foot is quite sensitive too, just to see whether there is a response. If there is no response, if the baby doesn't start breathing after the stimulation, you've got to go and get the baby to ventilate the baby, because a baby who doesn't breathe after stimulation is not going to breathe no matter how long you continue the stimulation for. So this is a baby where you have to be become active to open this baby's lungs. Positioning is really important, and especially if you're used to looking after more bigger patients and adults, the positioning is something which you need to do very consciously, because a baby's airway is very different to an adult airway. So the moment you hyperextend a baby's neck, you're closing off the airway. So it's really important to have a very neutral head position when you start resuscitating an infant to get some success there. In view of monitoring, we are using currently saturation monitoring, but this does come with its own issue, because obviously saturation will only come up if there's good perfusion. If you have a baby who's not breathing and is in a poor state, there might be no good perfusion. You don't get any numbers. So ECG leads are a really good monitoring tool in a newborn baby if you can make them stick, all right? Because remember, the baby comes out of water, it's really wet and slippery, and one of the issues with ECG monitoring is that these little stickers come off very quickly. So try to be inventive, put them on, the upper arm and wrap something around just to make them stick. That's really helpful. In view of the pulse oximeter or saturation monitoring, it's really important that we do that when a baby is not breathing on its own, when there is a need for ventilation or any breathing support, or when we suspect that there is any oxygen deprivation. The most important thing is that we place the oxygen, the saturation probe onto the right hand. And that's got to do with the circulation I showed you before, because even though you want to help that transitioning to happening, until then, you might have a right to left shunt through the ductus arteriosus rather than a left to right shunt. And what that does mean that everything which is sort of distal from the ductus arteriosus will give you a saturation which might be much lower than the saturation which is coming up on the right hand, and which is the oxygen which goes to the brain, which is really that is the oxygen we want to treat at the time. So within that golden minute, it is really important that we stimulate the baby, assess the baby, stimulate the baby, position properly, and if the baby is not breathing, that we start positive pressure ventilation, in particular if the heart rate is less than 100. And I guess one of the things to be prepared is also to know about normal physiology in a baby. I have had an experience where ambulance officers had attended a home birth, which unfortunately hadn't gone quite right, and the baby on their arrival looked quite pink, but had been still attached to the cord for the last 10 or 15 minutes or so, so had received a lot of blood from the placenta, making it look pink. And when they placed the ECG leads, the heart rate showed a very good signal of about 60 per minute, and those ambulance officers felt quite reassured at the time. And of course, you shouldn't be, because this is not a normal heart rate of a newborn baby. The normal heart rate is about 110 to 160. So this is what we're aiming for, to have a normal heart rate. And again, if the baby is not breathing, it doesn't really matter what the heart rate is at the time. We've got to make this baby breathe, because that's the only way to get the transitioning of the circulation happening. So ventilation is the main key element in neonatal resuscitation. It clears the fluid from the lungs. You know, the lungs are all filled with fluid because the baby's just been in amniotic fluid for the last 9 months or so, and they do breathing in there and sort of breathing movements, and it's all filled with fluid. And the ventilation will establish a good, adequate functional residual capacity in the lungs, and that will improve the blood flow in the lungs. If the baby is adequately ventilated, then the heart will receive better oxygenated blood, and what that will mean is that even if the heart rate has started off very low, just purely with the ventilation, the heart rate will slowly come up and will get back to normal. And it's really important to remember that the heart is actually one of the most healthy organs in a newborn baby, very different to, you know, your collapsed adult, where often the heart is the, you know, primary suspect for the collapse. In a newborn baby, the heart is one of the most mature and one of the most strong organs, and they will beat, the heart will beat very, very long, even when a baby is not adequately ventilated, or even in a very, very early birth below viability. So it's very important to focus on the ventilation. And it's very important to do the ventilation before starting any cardiac compressions, because if we do cardiac compressions but don't consider ventilation as one of the main steps, that will be futile, because your circulation is not going to change. So main goal in newborn resuscitation is ventilation. And we're talking about the newborn right after birth. Now, what's ventilation? Ventilation is A plus B, airway plus breathing, and that's the same in a newborn baby as well. So position the head very nicely in a neutral way, and clear the airway. Suctioning, you know, is a lot of debate about suctioning. Do normal, healthy newborn babies need suctioning? No, of course they don't, but we're not talking about a normal, healthy newborn baby. We're talking about a baby who's not breathing, who needs ventilation, and yes, we will suction the airway if we want to start ventilation. This is also important to manage potential obstructions, and one of the problems we sometimes encounter is meconium-stained lycra. I don't know whether many of you have seen that, but if a baby passes stool meconium for whatever reason prior to birth, generally infection or hypoxia, then that can be quite thick, sort of sometimes pea soup type of fluid sitting in the airway, and people were wondering how to manage this best. And it's taken many decades actually to develop the evidence for what has to be done when a baby is born through meconium-stained lycra. So what is very clear now is that when a baby passes meconium before birth and it's in the amniotic fluid with the meconium, that meconium is also going to be in the lungs. So these babies are at risk of meconium aspiration syndrome, a very horrible disease requiring intensive care, but we cannot prevent meconium aspiration syndrome by trying to crawl between the mother's legs and trying to suction the mouth before the baby takes his first breath, or the other thing we used to do not very long ago is to intubate those babies with an ET tube to suction what potential meconium is in the airway before we starting ventilation. And what's been shown is that all these things cause more harm than good. And what we do now with babies born through meconium-stained lycra is just we manage them just like any other baby. We do airway before breathing, so we suction their mouth and throat, and then we start ventilating them. And if ventilation is difficult, we start increasing the pressure and ventilate them harder. So it's really important in regards to the equipment as well that you have the right size mask, that it fits nicely around the baby's nose and mouth. This is how we ventilate a newborn baby with the head in a nicely neutral position. Once you do that, you want to observe the chest for chest movement. Because you want to make sure you open up the lungs appropriately, and that is sometimes really difficult for a baby who's not taken a breath, for lungs which are filled with fluid, where you have to suddenly put air in there. Think a little bit about those alveoli, like, balloons. It's probably environmentally, we won't use balloons soon anymore, but if you blow up balloons, what happens when they're kind of all collapsed and you blow in, like, it's really difficult to inflate them, right? But once you have a bit of air in, it's really easy. You get really easy the air going, like so easy that they sometimes pop, right? So it's a bit the same with the alveoli, those first few breaths, to just get them to kind of not to stick together anymore and to open up a little bit. You might need really high pressures, like really high, 40 centimeter water, 45, 50 centimeter water. But once they're open up, that's when it gets easier to ventilate. So once you can see the chest moving, you want to make sure you use less pressure. So that's really important to consider. So when you do ventilation, you confirm that that's effective by seeing the chest rise and fall nicely. Also by seeing the heart rate increase, because when you ventilate properly, the heart rate will come up. And if you have an oxygen monitor placed, you can also see an improvement in oxygenation. The devices we're using for ventilation, they are quite similar to what you're used to using, except maybe for the Neopuff. I don't know, I shall say a T-piece device. I don't know how many people would have used a T-piece device that is quite unique to neonatal resuscitation, and it is the device recommended by the Australian New Zealand Council of Resuscitation. But really it is, they do say that all of those devices are actually acceptable for newborn resuscitation, and really what you want to use, again, is what you're used to using. That's really important, that you know how the equipment works, and if you used to using a T-piece device, then that's fine. That should be your first device to use. But if you're not used to that, then either an anesthetic bag or a self-inflating bag or ladle bag will be just as good. Now, what's the important thing? Again, the important thing is that there is some form of PEEP, and a lot of the self-inflating bags or ladle bags don't have an extra PEEP valve attached. So this is something to consider, because PEEP, positive end expiratory pressure, is really important in neonatal resuscitation. And again, consider these alveoli all filled with water to start off with. You use high pressures to get them finally inflated. You don't want them to collapse every time the baby's breathing out, right? So the positive end expiratory pressure will keep the pressure in those alveoli and the air in those alveoli until at the time there's expiration, so that it's easier to do the ventilation. We do recommend to use a PEEP between 5 and 8 centimeter water if you are using a device where this is possible. Now, oxygen. Oxygen is very interesting because My experience is that emergency clinicians love oxygen, all right? The moment you attend a patient, first thing, oxygen, all right? Give them oxygen. As a neonatal clinician, I loathe oxygen, all right? Don't like it. Why is that? Because oxygen is a medication, yeah? Just like any other medication, it is very useful or very required in some situation, but it has side effects, and it has quite significant side effects for neonates. We know it creates free radicals, and we know that in newborn babies, it increases the work of breathing, it increases the oxygen consumption, and it also reduces cerebral blood flow, which is not good for the long-term outcome. Remember, those babies have been inside, kind of being fed and oxygenated by the placenta, which really gives them capillary blood more so than highly oxygenated blood. The normal oxygen saturation in a fetus, does anyone know what the normal oxygen saturation is? No one wants to say? It's about 60 to 70%, right? They're blue in there, right? So, you know, if women had like a translucent abdominal wall, they would section all the pregnant women straight away, seeing that baby, because it's blue in there, okay? But that's actually normal for a fetus, and when they're born, they not immediately turn pink like that. Some do, but it generally takes quite a while. So they are not used to a really, really high amount of oxygen at the time at all. Nature has actually done quite a few tricks to make them survive on relatively less oxygen as a fetus. We know from a very big meta-analysis, so lots of randomized control trials put together, that the use of 100% oxygen increases the mortality. And that's really, that was the last straw to really absolutely minimize the use of oxygen in neonatal medicine. And then you also see that picture. Anyone knows who that guy is there? Yes, it's Stevie Wonder. You know, Stevie Wonder is blind, and yes, he's kind of a little bit of age now, so it's been a few decades ago that he was born, but he was born prematurely. Not extremely prematurely, though, at 34 weeks with quite a bit of premature lung disease, and at the time, it was standard practice to use 100% oxygen for those babies because it made them look pink. And it probably at the time maybe helped them survive. But what it also caused was retinopathy of prematurity, which nowadays we really only see in 24 or 25 weekers. He had that, okay, and he lost his vision because of that premature eye disease with the use of 100% oxygen. So in view of oxygen, what do? We resuscitate term infants with air only, so no use of oxygen at all. If we have a baby who is less than about 35 weeks, we tend to use some oxygen, but generally not more than 30%. And then we increase or decrease the oxygen according to the saturation targets. Now, there is an exemption, and that really applies to neonates at all times, that if there is downtime, if there's no cardiac output, and we're doing major resuscitation, we use 100% oxygen at the time. So yes, if you get a collapsed baby into your ED or ambulance or so, it would be absolutely correct to use 100% oxygen. So what I'm talking about is really the time after birth where the baby has not taken its first breath yet. We will start with medical air rather than any oxygen. And the table we're basing the saturation targets on is published in the Australian Resuscitation Guidelines, and it's really based on how normal, healthy newborn babies adapt to extrauterine life and how long it takes them to get from their fetal saturation, which is about 60 to 70%, to a saturation around 90%, which we consider as normal. You find that in those in that newborn life support chart as well. So if you do have that printed out and ready to use wherever you work, you can have a sneak peek and you'll know always what your oxygen saturation target is depending on the minute of life. Now, again, ventilation, we've done all those first few steps. We look for chest movement, and if there is no response, really it is important that we start again from the beginning, not that we go and that we sort of jump on the chest and do the chest compressions at the time, but really focus on opening up the lungs and starting the ventilation to help the circulation to change. What do we do if the heart rate is not improving? We would need to check on the ventilation technique. Is the face mask appropriately sized? Do we have it in a good position? Is the head positioned correctly? Is the airway patent? And the most important thing is to increase the inspiratory pressures. So if you use a self-inflating bag, that's really not more than just squeezing harder, right? But if you use a device like the T-piece device, it is very important that you increase the pressures. If you started with pressures, say, of 20 or 25 centimeter water, that you go up to more. That's really important, and that's really important if you do that as a clinician working as, you know, a nurse or ambulance officer or paramedic, that just because it's a knob and you're turning something doesn't mean you can't do it, right? You have to do that. It's just like squeezing harder on the self-inflating bag. It is also helpful sometimes to increase the oxygen at that time to help really support that, ventilation and the oxygenation of the heart. If the heart rate remains below 60, you've got to increase the oxygen to 100%. That's really important. Now, how can we improve ventilation? Well, one way of doing that is to use a different technique, a different mask, and that could be something like a laryngeal mask airway. Now, I believe people in emergency care use LMAs all the time. For us, that's a little bit different. It's come very late into neonatal medicine. Actually, while we've been teaching that for a while, the first time I have seen a LMA successfully used for the resuscitation of an infant was around 2010 when I worked in Brisbane, and it was an ambulance officer who brought this successfully resuscitated infant into our ED, and we were all very impressed by the use of the LMA, I must say. So we're teaching this now to people, nurses, doctors who are working in neonatal care because it can be used very, very effectively. It's important that we acknowledge those LMA sizes. They're only going down to a certain size. So the size 1, which is the most commonly available LMA for neonates, can really only be used for babies down to about 2 kilo, which is about 34 weeks. So it's not very helpful for babies who are extremely premature. There is a size 0 LMA, but it's an LMA without a blow-up mask, and a little bit tricky when you have a baby with very significant preterm lung disease, because they often need really high pressures to get a good seal. So there is a size 0 you can use for infants as little as 1.5 kilo, but it's a bit harder to use. So these babies, generally, you will have to make use of the masks you have. Now, and then we have A and B, and hopefully with A and B, the majority of neonatal patients will actually come good, all right? If you do that correctly, you'll be good. That it is very, very rare that with effective ventilation, the heart rate remains really low and the baby is not responding. But if we do have a baby who, after all those steps, we're about 2-3 minutes in, we've done all the required steps to get really good ventilation, and the heart rate is still below 60, where we would start CPR, start chest compressions. Now, at the time, we've got to have the oxygen up to 100% if you don't already have that. But it is also important at the time to then consider IV access, because this baby is very, very unlikely to come around just with the chest compressions. You need other measures, you need medications to get this heart going. So it is suggested that by the time you start chest compressions, you get someone to get ready for IV access. The chest compressions we do with the 2-thumb technique, where we wrap our hands around the baby's chest. If you have an imaginary line from one nipple to the next, imaginary, but if it helps, I guess you can draw one. And dexiffo it right in the middle of that. We have the 2 thumbs and compress. And the depth is the same as in an adult. You go to about 1/3. Obviously, the number of compressions in a minute is a little higher, all right? We're aiming for quite a high heart rate here, although I tell you it's impossible to do 150 compressions in a minute, at least not sort of successful so that the heart can fill again in the meantime. But what we are aiming for is about 90 compressions in a minute, which get interrupted by the breath. And for a neonate, we do stop the compressions for the breath. So at a rate of 3-to-1, at a rate of 3 compressions to 1 breath, there will be no compression at the time you give the breath. And I keep losing track what the recommendation is in an adult, because sometimes there is a break for the breath, and then there's not, and then there's no breath at all, and now there is again. So I don't know. Probably have to keep track on that a little. For the baby, the breaths are actually the most important thing. Compressions, yes, they will be needed at that point to support your circulation, but do not lose focus on opening up the lungs in between. So at a rate of 1 to 3, we start the compressions, and we get someone to get access for IV adrenaline, because if you reach a time like this, it is very, very likely that this baby will need some adrenaline, and you want to get ready earlier rather than later. So we increase the oxygen to 100%, and the plan is to give the adrenaline IV as soon as possible. Now, how do we do that? We prepare for an umbilical venous catheter. Why is that? Because it is very difficult, actually, to put a cannula into a newborn baby when it's well. It is almost impossible to put a peripheral cannula into a newborn baby who's in downtime and needs chest compressions. Those veins are inaccessible. But we're lucky in neonatal medicine. Our newborn babies get born with their own central venous access. Yeah, the moment you clamp the cord, you have actually a cord coming out of the baby with a vein and 2 arteries. And that vein, you want to put the UVC in, the umbilical venous catheter, to give adrenaline. Now, what does this look like? A little bit similar to that. We always have a pack ready. So wherever you do any resuscitation in a newborn baby, all you need to do is open the pack, and everything you need is in there. So all really the person preparing has to do is to draw up saline and the adrenaline, make sure you have the line ready and flushed properly with the saline. You don't want to give the baby an air embolus by trying to resuscitate. And then you put the umbilical catheter into the vein. There's a picture with a cut-off umbilical cord, and it really looks a bit like that, although they all look a little different. But you have generally 2 arteries, and you have a vein. And the vein is actually a vessel which is not like nice and round. It's actually more like floppy because it doesn't have a muscular wall. So you can see when you look at those 3 vessels, the vein is the one which looks a little bit collapsed, but it's very easy to put a catheter in, while the arteries look a little bit more sturdy, and it's very difficult to get into the lumen of the arteries. And then there's D. D, obviously, for medication, drugs, medication. Yes, neonatal medicine, super easy, okay? Adrenaline, all right? That is the medication we use. There's very, very little use of anything else, okay? So if you have adrenaline, you'll be good. What we do use is adrenaline 1 to 10,000. You don't want to use your adult ampule. So there is an ampule coming with adrenaline coming in 1 to 10,000. But if you don't have that, you can obviously use 1 to 1,000 and draw it up into a 10 ml syringe with 9 ml of saline or so. So it is possible to easily prepare. If there is no possibility for umbilical venous access, the second suggestion is an interosseous. But you know, it's actually quite tricky to put an interosseous into a sort of a little tiny femur. I mean, it's hard enough in a 2 or 3 year old, but a baby's like much smaller, and the extravasation rate is much higher, so you need to be really careful. The bone is quite soft, though it is a bit easier to insert. We use adrenaline around 0.1 to 0.3 mil per kilo. But again, you know, no one knows the weight of the baby, so you kind of do a little bit like, if it's a term baby and really big and large, you give about 1 mil. If it's a preterm baby, you give 0.5. And if the baby looks like sort of only like half a kilo, maybe you give a bit less. There is no good evidence for endotracheal adrenaline. Now, for that, you firstly have to have an ET tube, which you don't really have at the time of the resuscitation, unless there is someone very, very skilled in placing an ET into a newborn baby. It's actually really, really difficult. So generally, the recommendation is to give that IV. And then the other drug we would use is volume. So normal saline, if there's any suspicion of hypovolemia, the most common scenario of hypovolemia in a neonate is blood loss. So if there is suspicion of hypovolemia, the saline helps you here and then, but do get O-negative blood as soon as possible to give to a baby, and about 10 ml per kilo is what we would start off with. E is actually really important in newborn babies because they are wet, and they are sometimes very immature. They lose temperature very, very quickly. So it is important if you resuscitate, actually even in a baby who's born relatively well, but born in, say, the emergency department or somewhere well air-conditioned, like in this room, this baby would get cold in no time. And that can cause lots of problems, and that can prevent the transition of that circulation as well. So you want to make sure you keep this baby warm, and that can only happen actively. It's impossible that a baby stays warm on its own. So if the baby is well, the mother's chest, abdomen, the mother's skin is the best place for the baby to be, with lots of warm blankets on top. If the baby is unwell and you resuscitate, you need to make sure that there is heating on, aircon off, heater in the room, depending on where you are. And for extremely preterm babies, we put them in glad wrap. Okay, so kitchen glad wrap will do, but we have now much more fancy stuff which comes packed up in sterile bags. But that's really important because they're wet. If they're wet and you put them into the glad wrap and you have nice heating sources on it, they actually keep warm really, really nicely. And put a hat on because obviously you won't wrap the head into the plastic, right? And their head is a very, very large skin surface, so they will lose heat very quickly just through their head. The main thing is really to check the temperature. Think of it. Think of checking and testing and making sure that the baby is in a really normal temperature range. And why is that? Because it has an impact on survival, especially in very low birth weight infants. So if you have a baby born who's less than 1.5 kilo, then we know that the mortality actually increases by almost a third with every degree of temperature below 36.5. So it's a really, really important step for ensuring that there is good survival. And once you've successfully resuscitated a baby, it is very important also to consider the post-resuscitation care. That you check those babies' bloods, that you make sure the sugar is normal, make sure the temperature stays normal. Think about the reasons why the baby needed resuscitation in the first instance. Infection comes to mind. It's one of the most common problems leading to an unwell newborn baby. So think of antibiotics and think of getting the baby into a specialist care unit where all those things can be facilitated. And last but not least, really important is the care of the family. The delivery of the baby is a really sort of, it's a nice thing. It's the moment which is cherished most, and everyone has these wonderful ideas of what's going to happen and has birth plans and whatnot. So if things go wrong in a situation like this, this can be devastating for the parents. And even if the resuscitation is very short and very successful, the parents are often traumatized for a very, very long time, and it's really important to address that straight away and to look after those parents really well. And if the baby is really well at the time, make sure you place it back skin to skin. This is one of the most important things we can do to really ensure that there is a good transitioning from fetal to neonatal life. That's it. Thank you.
Thank you very much, Ulrike. Do we have time for a question? Sure. Sorry, I'll give you the microphone.
Sorry, I just wanted to ask when it was appropriate pre-hospitally to clamp the cord for a neonate resus. You gave an example earlier of a crew that attended 10 minutes post-birth, and the cord was still not clamped. However, the baby was bradycardic. So at what point, let's say we're doing a home birth, and we've arrived and the baby hasn't been born yet, so we witness the baby's birth. At what point, if the baby's compromised, can we clamp that cord?
So the recommendation is that if the baby is very compromised and you've got to get the baby away from the mother to a field of, where you can appropriately care for this baby, you clamp the cord, all right? Well, if you can do your first steps of resuscitation while the cord is still intact, so if you say you're at home, you don't have a resuscitator and all this equipment with you anyway, but you have a little bag which you can take to the baby, then it would be appropriate to do those first few steps of resuscitation with the intact cord. But there is no sort of strong recommendation I can give, because we know it's of advantage if the cord is not clamped while you do the first few resuscitation measures. But if you can't do them because the baby is attached, then you've got to get the baby away from there. Yeah, so it's really important to just use common sense. If the baby really needs a form of resuscitation you can't provide between the mother's legs, then you clamp the cord and get the baby somewhere else. Yep. So when the baby is not compromised and it's a term baby, you put onto the mother's skin. It's actually quite important, even if the baby is somewhat premature, it will help this baby to transition, so you are better off to have the cord intact. The recommendation is to clamp the cord at 1 minute in preterm babies. In term babies, it doesn't really matter. You could wait for the pulsating of the cord to stop. So that's actually so relatively easy, because everyone sort of would have like a blanket or towel or something available. So the baby is born, is not breathing, so you wrap it in the towel and dry it quite vigorously. All right, that's good stimulation. Yeah, so it would more look like drying, but what you actually do is really good stimulation. And really, a few seconds is enough. If a baby doesn't respond to a few seconds of stimulation, there's something more wrong, and you need to start with the next step. We do use generally specific umbilical catheters, but actually you can use a nice long adult cannula if you need to take the needle out, so that you only have that plastic bit of the cannula left. And any adult cannula will do. You just have to make sure it's one of the longer ones. There's these really short ones. They're a bit tricky because you might not get in, but if you have a bit of a longer one, so a few centimeters, yeah, they will be good. Just don't use a gastric tube, because 20 years ago this was a really good go-to thing. You have a gastric tube, yep, you use that to cannulate the umbilical vein, but nowadays the gastric tubes have all different attachments. Yeah, they all have the enteral feeding syringe attachments, and they don't fit. Then you can't give medication, draw them up and stuff like that. So it's a big problem. So we had to do a lot of relearning. So no gastric tubes, but adult cannulas without the needle in it is good.
Okay, let's hear it one more time for Ulrike.
Thank you.
So that does draw to a close our first session for the week. Anand just wanted me to pass on to everyone, hopefully no one's done it yet, don't buy the audiobook that he was recommending. Apparently it's not a great read with the actual audiobooks. I think that was Thinking Fast, Talking Loud. You're going to have to do the work yourself and read the book. It's much better read than listening. Tomorrow, it's an early start. So 7:30, we're going to be kicking the presentations off. 7:20, we'll have the food out the front with lots of coffee and teas. So that's for tomorrow morning. For those that have not yet grabbed one of the black EMS conference bags, we do still have a large number at the back of the room, so please grab one of them on your way out. There's a stubby holder that may come in handy tonight in there, so don't forget one of those. And just a reminder that Scott and Alex will be kicking things off straight away now with our optional session, which is our Finance Fundamentals one. If you're heading off now, hope you have a great evening and looking forward to seeing you all tomorrow morning. Cheers, guys.
Check, check. Check, check, check. Check, check. Check, check, check. Check, 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 check. Check. Ini nomor 4. Check, check. Check, check, check. 4 tambah 1.
These were the things. Is our presentation or just Oh, it's already. Is that one? Hey, mate. Yeah, they're all recorded, I think. Yes.
Is that one getting really bad feedback?
I just turned it off. Oh, that's why.
That's right, this should work. Fine. Okay, guys. I reckon.
Yeah, we're all good. We'll just maybe just stand either side of this thing. Stand either side of this. Yeah, yeah. Good afternoon, everyone. Thanks for staying back and staying for our session. So this evening or this afternoon, we can kind of take this in any direction that you guys want. So we want you guys to get the most value out of it. we've got a heap of slides around kind of fundamentals to your finances, so how to kind of set yourself up for no matter what kind of stage of life you're at the moment. So we'll cover topics such as house purchase or refinancing, superannuation, personal insurances, and investing in the share market and or property as well. So we'll cover a lot of topics, but we can kind of skip over some if they're not of interest to the majority, or we can delve into more in further detail as well if you guys have particular questions. So my name's Scott and this is Alex. I guess just starting the boring slide first, if I work out how to... It's just a general disclaimer warning. So this is just general advice only, so it doesn't take into account your personal situation. So whatever we do say is general in nature.
Cool. All right. Thanks, Scott. So yeah, some of the things that we'll sort of cover today, firstly around property and purchasing a house, and all things to do with property effectively. Your superannuation, so we'll talk a fair bit about that as well in terms of things to look out for there, things to consider when you are looking at your own superannuation and thinking about your own retirement. Personal insurance or protecting your wealth, so we'll talk a bit about income protection as an example, or life insurance and how that potentially sort of can fit into the mix. And finally talking about investing predominantly towards sort of the share market, but mainly I guess what we're talking about here is investing outside super and some things to consider there when you're looking at that.
Cool. Can I just get a show of hands who owns a property in the room? Does everyone own a property? Majority of people. The people that didn't put their hand up, have you owned property before? No? Yeah, okay. So there's probably half a dozen or so ones that don't. So I guess what we're going to touch on is kind of building your property portfolio, but if you haven't bought one before, there's a few tips that we'll quickly run through as well. So when buying your first home, your second home, your dream home, your investment property, there's a few considerations that we like to take into account. Firstly, where is it located? Now, in terms of a principal place of residence, this doesn't matter as much because you're not buying it for an investment unless potentially it is your first home and you're trying to jump on the ladder to climb to your dream home, which may be out of reach now, but it's kind of a future kind of pipe dream. So it's kind of considering at all times where we're actually purchasing. So ideally it's not on kind of a main road, it's near schooling, it's near train or public transport. So there's some of the things that we want to, I guess, consider. You can speak to the local councils, town planners and that as well to see kind of what's coming up in the area, if there's any new developments and things like that. And typically a mortgage broker will have access to information that the general public don't have access to around, is it in a flood zone or not, and kind of things that people don't generally think about when purchasing property. The second consideration is around how much deposit do I need? Now, it's becoming harder and harder to get into the property market if you don't have a property at the moment, given that prices are rising quickly and you need a substantial deposit. So you need at least a 5% deposit to get in, but ideally when you are purchasing a property, you do have a 20% deposit because then you avoid extra costs like lender's mortgage insurance. So in terms of that, as an example, on $1 million home, that's 200 grand plus stamp duty, which is probably going to be close to 300 grand as an example. Now, there's some occupations that you can avoid lender's mortgage insurance with, such as doctors, accountants, lawyers, and so forth, and then you only need a 10% deposit. So if you're a doctor or if you've got a partner or spouse that's one of those occupations, that's important to note as well. Lender's mortgage insurance, though, at the end of the day, is not the worst thing. We would suggest if it is kind of going to take you a lot longer to save for the next house or your first home, potentially to pay the lender's mortgage insurance and capitalise that onto your loan. So i.e. that goes onto the loan, you pay a higher repayment, but at least you get into the property market. The risk that you have is if you continue to try and aspire to the 20% deposit, that 20% deposit keeps getting higher and higher as the property prices rise. So that's obviously the risk with that. Other costs with property is stamp duty. So everyone probably knows about stamp duty. So whether you've purchased a car or property before, there is stamp duty. The higher the value of the property, the higher the stamp duty charge. It differs as well state to state. First home buyers in the room, there are stamp duty concessions, so be aware of that depending on what state you're in. As an example, New South Wales, if it's under 800 grand, there's stamp duty concessions versus WA, it needs to be under 530, so it's very different kind of state to state. What will cash flow look like post-purchase, which I think is really important given the higher interest rate environment we're in at the moment. If we kind of reflect back on the last few years where it's been 2 or 3%, it's been kind of abnormal, I guess. The long-term average in Australia the last 25 years has been 5.64%. So we're kind of a little bit above the longer-term average. So in terms of where we're at the moment, it's probably going to remain around this, maybe 1 or 2 more rate rises, and then we should see some drops as kind of inflation comes down. But what you want to map out is if you're looking to purchase a property, what impact's that going to have on your lifestyle and your cash flow, or if you're upgrading. So quite often we're starting to see people now that put themselves in a position where they can't move on to their next stage of life, which may be having kids, winding work down, or whatever it may be, depending on what end of the scale you are, because they've got themselves into a situation where the repayments are quite high, and it kind of forces them into that income for the foreseeable future. And then lastly, just setting yourself up for future purchases. So what we're talking about here is just being aware of an offset account versus redraw and the functionality around that. So what we would suggest is if you've got a house, or if you're looking to purchase a house, potentially utilising the offset account in more often than not cases. Reason being is if you're using that to purchase another house in the future, and that might be 10 years, 15 years time, it's better to build up the offset account to use that money for the next house deposit if you're likely to keep the current house. Okay, so what I mean by that is when you're, if you're retaining your current property that you're living in and trying to kind of grow into your next property, you ideally want the mortgage on your current property to be as high as possible, therefore using the offset account to put down as a deposit on the next property, which then means your current property that you're in that's going to become an investment is more tax effective in the future. Whereas if you pay it off quicker and build up your redraw and then pull out that equity in the future, that equity you pull out is not tax deductible in the future. So it doesn't matter if you're only planning on holding one property at all times. If you're always going to sell, buy, sell, buy, sell, buy, then just pay it down, because you're just your next deposit's going to be the sale proceeds. But it's more so around if you're planning to build a portfolio, to just understand the differences there and the tax outcomes in the future, not just now. Any questions so far? Yep. Yep. Yep.
Yeah, cool. So the question was the difference between redraw on a mortgage versus an offset. So the easiest way to think about it is let's just say you've got a $500,000 loan, okay, that you've gone to the bank, asked for the money, they've lent you $500,000. Usual loan term would say be 30 years, 25 years or something like that. So that's basically how long you have to pay back this $500,000 is 30 years plus interest, okay? Now that will basically give you a minimum repayment at the current interest rate. Now if you pay above that, okay, so more than the minimum amount, okay, that will often then build up what's called a redraw, okay, because effectively what the bank says is you've got 30 years to pay that back, okay, and you can pay more back at a period of time and then take it back. As long as you're always giving us this minimum, then that's fine, okay. That's effectively what redraw does. So if you pay extra, okay, it will lower the interest part on the total loan, okay. Offset works exactly the same way. However, it's just money in a different bank account. So if the loan's $500,000 and you've got $25,000 sitting in a separate offset account, the total interest being charged on the loan will only be on $475,000 as opposed to $500,000. The advantage of this, potentially of what Scott was referring to before, in terms of from an investment property perspective, is potentially you're living in, maybe it's your first house or your second house and you don't intend on being there forever and you want to turn that into an investment property in the future. It may make sense, therefore, to build up more money in offset. Okay, so you build up that 25 grand in offset, and then when you go and buy your next house, you pull that cash out and use that towards your deposit of your next house, which then makes the interest on that full $500,000 loan deductible. Whereas if you had the $25,000 sitting in redraw, okay, which you could still pull back, okay, technically the interest you could claim on that loan would still only be the $475,000 part, not the full 500. Yeah, so that's taking your redraw out. So you could take it back out, okay? So you can take it back, it's exactly the same. It's just the difference is often from an investment property perspective, because you've technically then paid that part of the loan off, okay, before it was an investment property, that part of the loan won't actually be, the interest on that won't actually be claimable, as an example. But they do work largely the same. They work exactly the same in terms of how much interest they're offsetting on that loan. An offset account will often cost a little bit extra money as well, depending on the lender as well, something to consider. But it just effectively means it's maybe a little bit more flexible if you are thinking of maybe turning that property into an investment property in the future.
Yeah, redraw it then is fine. Yeah.
Correct, yeah. The other hypothetical risk with redraw is the bank can technically take that at any point in time. Now, that's very rare, that doesn't happen very often, but technically they could take that money because you have technically paid it back, okay, and then they could clear it as an example.
Yeah, so you don't lose the money, it comes off your loan, but then you need to then go through an application process to get that money back. Then that's based on your income, your situation and stuff, so it may be hard to pull that equity back out in that case.
And where offset potentially is more flexible, even if it is your final home, is potentially you are thinking about retirement. So as soon as you retire, they're probably not going to lend you any more money because you no longer have an income from a wage, as an example. So potentially parking that more in offset as opposed to redraw still then gives you access to a large lump sum of cash if you suddenly need it for some sort of reason as well. You are, because remember, you've got to have that payback within, say, whatever the loan term is, 30 years or anything like that. So you'll still do your minimum, okay? However, you just won't be paying any interest, okay? So if it's, say, it's a brand new 30-year loan, $500,000 borrowed, you immediately offset that with $500,000. Over 30 years, that the money and the loan would just slowly drip down to zero. Does that answer that a bit? Does that make sense?
A bit more. Thanks for the question. So what we just wanted to quickly just run through for those that haven't bought a property before, or those with younger kids who may be looking to purchase soon, is utilising the First Home Super Saver Scheme.
Cool. All right. So, as Scott mentioned, if you haven't purchased a house before, this is a government incentive which was brought in about 5 years ago now. Effectively, what it is in a nutshell is a way that you can save tax, okay, which effectively then gives you more money, which you can put towards your first deposit. So what you're allowed to do is put extra money into your super fund. So it needs to be above the super guarantee rate that your employer has to put in. So it has to be an extra amount, either through salary sacrifice, which you guys may have heard of before, or you make what's called a personal contribution, okay, which is an after-tax contribution, which you then put on your in your tax return. The net effect is identical. So some sort of method through that. What that means is that money is then taxed at the super fund rate, which is 15%, as opposed to your own personal rate. So in this example, we've used 34.5%, which would mean you'd be earning between $45,000 and $120,000 in this example. The more you earn, by the way, the bigger tax saving you'll have. In terms of how much you can put in under this scheme, it's $50,000. However, you can only put in $15,000 per financial year. What we've given here is just a bit of an example of, say, one financial year, so the full $15,000 during that year. The money goes in, okay, into super. It's taxed at 15%, so that 15 grand gets turned into 12,750, okay, in this example. You are then allowed to withdraw that back out the other side if it's to be used towards the deposit of your first home. There is often a tiny little bit extra tax to pay, and there's some earnings that are deemed on that as well. We haven't really run through that on this slide because it becomes a little bit complicated, but effectively the numbers stay sort of as they are here. And the difference we've got here, as opposed to you receiving that 15 grand in your own name and putting it in just in a savings account. Okay, so the difference is about, I think it was about three grand, okay, for this person in that financial year. And remember, they could do this another 2 more times as well. So for the average person, earning anywhere between 45 to 120, it's worth around 10 grand in tax savings, which is then just simply extra money they can put towards their house deposit. In terms of the rules around this as well, there's no income level restriction or anything like that. You just simply can't have bought a house before, and you need to live in it for the first 6 months of the first 12 months upon sort of purchasing it. And it's available as well potentially where you've got a situation where a partner's already bought a house, and then you're gonna go and buy a house with that person. You can still use it in that example as well, which often sometimes knocks out other first home buyer concessions that states offer.
And it also helps people that are poor at saving money because it's out of sight, out of mind. It's in their super. They can't touch it or get it back until they purchase their first property. So not only those tax benefits there as well. I guess we just want to finish off on renting versus owning. We often hear the statement of, I'm paying someone else's mortgage if I'm renting. It's not actually the case anymore with where interest rates are. So just a quick example here of kind of a median kind of mortgage these days, which has slightly gone up the last few months. It's around 700 now, but use 650 here as a mortgage. That's kind of on an 800 grand property. Rent for that would be roughly 550 a week. So you're paying kind of 30 grand a year in rent versus mortgage repayments at 6% of $900 a week. And of that $900 in the early years, $750 of that is interest. So I guess that I'm paying someone's mortgage, it's a lot cheaper to rent if you can find a rental at the moment. So from a cash flow point of view, it makes sense. But the benefits of owning a property, particularly the last 3 years, the property market has gone bonkers all across Australia, and therefore you would have been way better off. But yeah, it's just down to kind of what you need, but or what you're looking for at the moment. But it's just kind of showing here that renting is cheaper, generally speaking, than having a mortgage from a cash flow point of view.
Yeah, so that's why it's particularly important if you don't intend to own a property in the future that you are doing something else with your money to effectively compensate that, because often having your own principal place of residence, it's often a forced way of saving as well for people too, because they just get used to paying that mortgage over time, and the asset appreciates, as Scott sort of went through before. Of course.
Yeah, and I do agree with you, and sorry if I glossed over that point. From a cash flow point of view, so your money in versus money out, you're in a better position renting, but from a wealth creation point of view, you're worse off. Yeah, so sorry I glossed over that, but I do agree with you there, yeah.
Does that make more sense now, what I point was?
So yeah, to Alex's point, if you are renting, you should potentially be looking at investing, say, in the share market and building your wealth through other means outside of property, if that's not a goal of yours.
Okay, superannuation. Okay, so not always the most exciting topic, but is quite important. So super, for most people in this room, will typically become your largest asset, if not sort of your second biggest asset behind potentially the family home, if you've decided to sort of go down that route. So it's very important, therefore, that we basically pay attention to it. So yeah, that's that point. Thank you. As I mentioned before, and as I'm sure you're all largely aware of, when you are working and earning a wage, your employer has to contribute some of your wage towards super every pay cycle, and then currently that's sitting at sort of 11% and is earmarked to go up again to 11.5% next financial year. A super fund is the best tax structure that you have available to yourself currently, so it only pays tax at 15%. So it pays 15% on the way in of any contributions, and then any money that money makes, it also pays 15%. So in most people's cases, similar to the slide I was sort of showing before, if you're earning between 45,000 to 120,000, you would pay 35.5%. So the super fund is paying less than half that, as an example, to sort of put that in perspective. And then similar to what we touched on before with the first home super saver scheme, if you're not doing that, you can still do this as well around salary sacrificing extra money in. And that's one of the key reasons why people often salary sacrifice money into their super or extra money, because then they're only paying tax at 15% as opposed to 34.5 or 39 or 47.5, depending on where you sort of sit within those tax brackets.
Yeah, and a good strategy with that, if you're heading towards retirement and you're nearly at the age of accessing your super, which for most people in the room will be the age of 60, is salary sacrifice. Even if you have debt, salary sacrificing money into super so you pay less tax, and then you can access your super to clear your debt at a later point in time as a lump sum. So that just means a better way of making your money work harder for you and paying less tax to the ATO, but still getting to the point of a comfortable retirement and being debt-free, just in a different kind of way of doing it as well. In terms of reviewing your super, so a lot of the time people will stay with the super fund that they started with or joined depending on their workforce, and we'll just assume that is the best one for them. And I guess the earlier you can do this, the better, and the longer you have for this to compound and take bigger effects with the changes you make. So some of our tips, I guess, for reviewing a super fund is firstly making sure it's consolidated. So you're not paying extra fees, and the fees are super fund fees, but also insurance costs. So if you have multiple super funds, potentially you'll have multiple insurances in there, and that you may be overinsured or paying for stuff you can't actually claim on. Easiest way to check this is on MyGov. You might also have lost super, so if you have super accounts from back when you were a teenager or whatnot, and they were less than $6,000, they would have been sent to the ATO by now and be sitting as lost super. So it's best to go and claim that, because that money's not doing anything for you. It's not going backwards, but it's not earning anything. So it's best to get that into your hands, into your super fund. Look for a low fee fund. Harder said than done, because you do need to go through the product disclosure statements, which will be very, very boring. But all super funds charge a percentage fee of your balance. So if you've got, say, 50 grand and the fee is 1%, which is the industry average, you're paying $500 a year. If the balance is 500 grand, then you're paying 5 grand a year. So you can kind of see the more you have, the more you pay, which is why it's important to review that percentage fee you're paying. And the earlier you can do that, the longer it has to compound and make a bigger saving or outcome to you. Review your investment options. So that, again, quite often most people will just stick to their default option that the super funds allocated them to. You do have the choice of where your money goes, okay? And when I say that, the difference between sitting in kind of defensive assets like a bank account or cash versus the share market. So you can kind of be on any end of that scale. You can be aggressive and be all in the share market, or you can be very defensive and sit your money in the super fund's bank account. So you're never going to see it go down, but it won't appreciate that much in value, maybe 3 or 4% on average a year. So depending on your stage of life, we would suggest kind of different profiles or a different kind of mix of that. So if you're 20, 25, you probably want to be quite aggressive, because we've got 40 years until we can touch this money. So if there's a few share market downturns, financial crisis, then we have time for that money to recover. And history tells us the share market will average 8 to 10% a year versus kind of long-term cash rates of 3 to 4%. If you're, say, 50 and above, potentially you want to be fully in the share market, because if there is a crash and our account drops 20, 30%, maybe we don't have enough time to let that recover. During the global financial crisis in 2007, it took about 5 or 6 years from the peak for it to get back to the kind of the previous high. So it does take time to recover. It always does recover. It just takes time. So if your time from accessing your super is getting shorter and shorter, then it's equally as important as when you're younger. And then reviewing your death benefit nomination. So there's only a couple of funds in Australia that doesn't allow this. So those in the room that are with GESB, you can't nominate a beneficiary. But nominating a beneficiary is super important. And nominating a valid one, okay? So what is a valid nomination? There's 4 types of people. Your spouse or de facto, a minor child, so under 18, an adult child under 25 that's financially dependent on you. So they live at home, go to uni as an example, and someone you're in an interdependent relationship with. So what that is someone you physically and or financially care for. So again, quite often we will see people that have nominated their mum, their sister, a friend, someone like that. They're not actually a valid nomination under those 4 criteria. So what would happen if they were to pass away? The super fund would reject that nomination and then it would go to the estate. So best practice there, if you're not nominating your spouse or de facto or children that are under 18, is to nominate your estate, which is your will, and then have a valid will up to date. That's the safest way to get around that if you want to nominate a sibling or your parents.
And just on that as well, quickly with the nomination, even if you do have a spouse as an example, but you don't intend to leave your super fund to them for some sort of reason, and it's effectively then done through your will, it is making sure that you have correctly nominated your estate, because if you haven't, the trustee will use their own discretion in terms of where they send the money, i.e. they could still send it to your spouse because they'll just decide that that's what they want to do. All right. Just tying what Scott was sort of saying then together with a bit of a graph. So in this example, it is looking at effectively making sure our fees are as low as they possibly can be, and then also the difference between 2 funds. It's not showing too well there on the projector. So we're looking at a balanced investment option, which is the blue one, and a high growth one, which is the green. In this example, this person is 27 years old. They've got a $40,000 balance in their super fund, and they earn $90,000 a year. The blue one, the balanced investment option, so that will have about a 50-50 split between defensive and growth assets, and we've assumed it earns 5% a year on average. The green one has got a 85% split towards growth and 15% towards defensive, and we've assumed it earns 7% on average, so only a 2% difference. The blue one is paying fees of about 1.2%, which is typically the industry average, whereas the green one is paying 0.55%. If we then extrapolate that out over this person's working career from 27 to 65, the end difference between the 2 balances is almost $800,000. So the key here looking at this is effectively to look at your super fund ultimately and make sure that you are paying as little fees as you possibly can, and it is invested correctly for your current life stage as well. And one thing as well, I guess I'll add to that, is towards the end, so when you can sort of start to see retirement and things like that too, it's making sure that you're not necessarily going too conservative as well. So not just moving everything to cash as an example, because that will potentially affect your long-term returns still going forward, because most people don't intend to, I imagine, turn 60, retire and then die a year later, okay? You could potentially still live for another 30 years. So it is making sure that you are leaving enough money there to still make you more money in the event that you do potentially live to 90 or 100 as an example.
Any questions on super, guys, or want us to take any different directions there, or all good with that? Yep. $1 million question, maybe $1 million. It really, so you'll hate me for saying this, but it depends. What we look at with retirement planning, which we'll delve in a bit more in our session tomorrow, but it's more about what your lifestyle is, okay? So your lifestyle compared to mine may be, you like traveling and spending 30 grand a year on expensive overseas holidays, whereas I just like going out in the bush and camping as an example. So in terms of that, in terms of retirement, you'll need more money than I do. So firstly, we work that backwards, but the comfortable kind of lifestyle that the government is saying for a single at the moment is 52 grand a year tax-free. And
for a homeowner.
For a homeowner, and 70 grand for a couple. So in terms of how much you need for that to sustain is a tad over $1 million.
And again, you're pulling a bit of a face there, Sheree. So again, and that's why it is kind of how long was a piece of rope kind of question, because 70 grand to some people or to a couple may be plenty of money. To other people, it may be nothing as an example. So that's just a guideline. that they try to put out sort of every year. And in that example, it assumes that you own your own home, means that you can pay all your bills, you can have medical insurance, you can go to the movies, have a gym membership. It includes one overseas trip every 7 years, which for most people in this room is probably not going to be acceptable. Or so again, it really does come down to your own personal circumstances, and you do need to sort of think about that as soon as you can.
And I guess like with this graph, that blue line is just getting a tad over $1 million, and this person's earning 90 grand a year. So the benefit, I guess, that younger people in this room have is you're forced to save for your retirement from day one, and it's kind of 9.5% or above from day one, whereas it hasn't been around and mandated for that long in Australia. It's only kind of 30 years now. So as kind of the younger generation hit retirement, they're going to have a lot more money. So retirement, the government pension will kind of cease to exist in the future, we believe. But that's where it's still an important part of someone's retirement plan now, because people retiring now haven't had super their whole working lives. And if they had, it started off being kind of 4-5% of their wage, which was lower than it is today.
Yep, question? So the question was, is there a difference between a self-managed super fund and just a normal super fund? Was that? Yeah. The answer is no. There is no difference. A self-managed super fund gives you more flexibility, possibly in terms of what you can invest in. So the classic example of that is you could buy a direct property in a self-managed super fund, whereas through a standard industry fund, you'll have property exposure, but you won't be able to buy a residential property. We are running through tomorrow in detail around self-managed super funds, when you potentially would have one, pros and cons, the costs, those sorts of things. But in terms of from a legislation point of view, there is absolutely no difference between the two.
Yeah, so same tax rate and stuff, but if you want property or buy artwork and stuff, then you need self-managed super fund. On the other side, there's a lot more, you're in charge of your own super, so a lot more compliance risk, so you need to make sure you understand the rules, otherwise the ATO will penalise you because now you're the trustee of your fund. So a classic example we see is people will move money out of their self-managed super fund bank account, put it onto their mortgage, say, I'll transfer that back in at a later point in time. That's a breach, because you're under the age of 60 and can't get access to your super, as an example. So there's a lot more kind of compliance risk with doing it as well. Alrighty, another interesting topic, personal insurance, when it pops up. So this kind of follows on from the super fund conversation and having a review of what's in your super, and a lot of people will have default levels of insurance. So it's important to look at that. And there's potentially 4 types you may have. So life insurance, probably the easiest one to understand or comprehend. If you pass away, a lump sum of money is paid to your family or your beneficiaries. Total and permanent disability, so this pays out if you're unlikely, keyword unlikely, to ever work again in an occupation you've got reasonable skills, knowledge and training in. So it's not you're a complete vegetable, you're never working in any industry ever again or any job. It's any kind of suitable job with reasonable skills and training. Trauma insurance, probably better termed here as critical illness. So this pays out upon 45 conditions, most notably cancer, heart attack, stroke, but 45 kind of included in that as MS, Parkinson's, motor neurons and so forth. This pays a one-off payment if you're diagnosed with one of those conditions, which then helps with medical bills. And then lastly, income protection. So this protects your income, which we believe is one of the most important assets you have, is your ability to earn money. This protects that. So if you can't work because you're sick or injured, mental health related as well, this will pay out 70% of your wage, up to 70% of your wage, until you're able to go back to work or until the benefit period ends.
Cool. All right. So then we'll just very quickly explain then potentially looking at these types of covers, when you may consider them or not. So when it comes to life insurance, you generally would have it if you potentially have a mortgage debt, as an example. But mainly it's if you need to provide future living expenses for your family or you have dependents, i.e. if you're not around anymore, people are going to suffer financially as a result. That's generally when you would consider potentially having it. Total and permanent disability, so as Scott mentioned before, an injury or illness that you've suffered and now you're unlikely to ever be able to work again. So we would consider, again, potentially covering the mortgage in that example. But the biggest thing for most people is that future loss of income. So what we're referring to here is everyone in this room is obviously qualified and earns a decent wage and stuff like that. So you yourself are an asset, okay, or a money-making machine. If you suffer an injury, illness, and then you can't then realise your potential over that working career, you then have, as a result, have missed out on making a fair bit of money due to that. So it's potentially looking to insure some of that through TPD as an example. Trauma insurance or critical illness is a better way to explain that. Again, you look to potentially just have this in place that if you do suffer one of these illnesses, you have a small lump sum of money there to help with any sort of short-term income loss and potentially help with any out-of-pocket medical bills that you may have. And then finally, income protection is just simply replacing your wage. So instead of being paid by your employer, you now get paid by the insurer as a result.
Yeah, so I guess what we're getting at here, most people will have life insurance, permanent disability, income protection in their super as a default. It's normally not enough. Most super funds will only give you kind of $2 or $3 grand per month, and most people in this room probably could get $6-7 grand per month cover or more. It also normally has a limited benefit period of 2 to 5 years, whereas you can get one that pays you until you're 65. So it's just kind of looking at the insurance as part of the super fund review as well, and just making sure that you're not paying for stuff you don't need. Say you're single, you live in your own home, and you're paying for life insurance. Maybe you don't need that, because if you were to pass away, the house gets sold, clears the mortgage, and there's super and other assets left for your remaining family. So it's just kind of reviewing that you're not paying for stuff you don't need, but also you're not underinsured as well. Any questions on insurance? No. Yeah. Yeah. So you can these days you can have an independent organisation, but still have it paid from your super fund. So you can kind of have the best of both worlds. I have the best super fund for my position, the best insurance company for my position. They can talk. I can sign off that they talk. The other, I guess, part to that is it better that I pay for it out of my cash flow or my bank account versus my super? Income protection is probably the only one that makes sense for the bank account to pay for if we can afford it, because it's tax deductible. Whereas if it comes paid from my super fund, it's tax deductible but at 15%. Versus my marginal tax rate of 34, 39, 47%. So income protection is probably the one out of the life insurance, permanent disability that you may already have that would make sense to pull out if you can afford it. Yeah. Thanks for that.
Yeah, it's just really considering the tax deduction and whether you've got the cash flow when it comes down to it. Life insurance, for example, you can get the best of both worlds in that you can get a tax deduction inside your super fund at 15%, so basically 15% cheaper. And then if it's paid to a spouse, there's actually no tax paid on the benefit. Okay, whereas generally if you're getting a tax deduction, if you then get paid the benefit, there'll be tax to pay on that.
Cool. We just want to just quickly close off just with investing. So whether that's property or investing in the share market. Has anyone here kind of started investing or done lots of investing in the share market before? One or two? ETFs, yep, cool. Great. Yeah, not so serious shares. So why do we encourage people to do this? So it's to build their wealth quicker, and we encourage people to start earlier to building their wealth so that they've got options earlier in life. Most people will be able to access their super fund from 60. That's what it is at the moment. Potentially that age will go up as time goes on. So you may not want to work until that age. You may want to semi-retire, fully retire, or have options before you can access your super. So in order to do that, we need passive income, whether that's through investment properties or shares, okay? I guess why we're talking about shares is because it's more flexible than property. If you need money, 10 or 20 grand, you can't just sell part of the property, whereas shares, you can sell portions of it and get that money as an example, okay?
Cool, and yeah, we are big advocates of property as well. I guess, yeah, what we're talking about here, those shares is basically a little bit less common, and you can start with significantly smaller amounts of money. Okay, so 4 things to think about when you are doing sort of any investing. Okay, and in this example, again, we're talking about investing outside super. So firstly, it's thinking about the time frame. So the time frame is basically how long until you want the money back is the easiest way to think about that. So for example, it could be a year, it could be 10 years, it could be 20 years. And depending what that time frame is, then should help us in terms of which pathway we pick, in terms of do we go for more growth assets like property or shares, which generally you need to hold for sort of 10 years plus to effectively guarantee that you'll make money. Or if it's only a year, as an example, is potentially a savings account a much better idea, because we're not going to get any volatility, but we're also not going to get the same return per se either. Number 2, diversification. So what we're talking about here as well is the old adage of not putting all your eggs in one basket, as an example. So to sort of relate it back to property, something that we see quite often is often people will buy their first house, and normally that goes relatively well over time, but then they may look to buy an investment property, and often they'll buy, say, the street over or the same neighbourhood or something like that. There's nothing necessarily wrong with that, but that does mean that then they have a lot of money correlated in one spot, so they will be then their return will be very beholden on what those properties do, which are only in one country, in one state, on one street, as an example. So it's making sure that we're considering all opportunities per se, because potentially there's other places that we can make more money, and it also reduces our risk. So in the share market, for example, if you're buying miners and you're buying financials, so banks and BHP per se, and the miners aren't doing very well, so we're losing a bit of money there. However, the banks are doing really well, so we're making money over here. And that's basically what diversification is. It's spreading that risk. Number 3, ethical preferences. So within the share markets, or ETFs per se as well, there are now a lot of options that if you do want to invest ethically in a certain direction, so for example, if you don't want any exposure to fossil fuels or mining or something like that, there are a lot of products that you can now utilize that will enable you to do that. We just do encourage, though, don't just buy it if it says ethical. Make sure that you actually read the charter, i.e. what they stand for, what their ethics are, and they align with your own. And you can, with all ETFs as an example, you can check the top 10 holdings. So we just bring that up because often when clients come to see us, they may have bought an ethical ETF or they're in an ethical super fund, but they don't actually know what it's investing in. And to be honest, more often than not, when they do know, it doesn't align with their ethics. So just bear that in mind. And then finally, number 4, the instrument to purchase. So once you sort of had a bit of a think about these things, it's, do I buy direct shares? So buy BHP as an example. Do I buy something called an ETF, which stands for an exchange traded fund? Do people know what ETFs are when I say that? Okay, so some people are nodding, some people are shaking their heads. So an ETF, which stands for exchange traded fund, okay, so effectively just means that something that you can buy on a stock exchange. So you may have heard of the ASX before, which is the Australian Stock Exchange. ETFs have become very popular over the last 15 years because they allow retail investors, which would be pretty much everyone in this room, okay, the opportunity to potentially buy or get diversification very easily for a small amount of money, i.e. you could buy an ETF for $500 and the underlying holdings within that ETF may be the ASX 200, okay, which is the top 200 companies listed on the Australian Stock Exchange, okay, for one transaction fee. Whereas prior to that, if you wanted to get all 200 companies, you would have 200 transactions, which again, for most people in the room would just wipe them out with cost. Does that make a bit more sense now? Yep. So that's what an ETF is. It's effectively a basket of shares, and there's tons of them these days in terms of what you can do. And then obviously property, which we've talked about a fair bit as well. All right. I know it's very late in the day. There's only got 1 or 2 more slides left. So quick pop question, which potentially will go off script as well, and we'll give our door prize to whoever, if anyone can answer this within $20,000, we'll say. Okay, if you invested $10,000 30 years ago into the Aussie share market, how much do you think it will be worth today?
How much? 3 million.
3 million, 1.5. All right, you're all going to be sorely disappointed, but The answer is,
Vastly
well, as of the end of last year, this is slightly out of date, but as of the end of 2022, it would have been worth 131,000, or it would have returned 9.2%. I know it's a bit blurry in terms of the Aussie share market.
Yeah, but you compare that to cash, and I know it's hard to see, but it's the kind of the one above the red line. Doesn't ever go back, but it's very, very straight, right? And that gets to 35 grand. So 10 grand in 30 years sitting in a bank account, just getting interest over that time turns into 35 grand versus 131 grand if it's in the Australian share market, or if it was in the US share market, $182,000. That's not contributing extra, which is why people may have said 1.5 or 2.5, but your door prize is safe, Quint, for tomorrow. Just to, I guess, finish off, just showing, again, kind of some projections. These are pretty basic projections, but just if we are to, say, contribute a little bit of money every month to an investment portfolio of ETFs or shares, whatever it may be, and if we kind of average close to 7% a year, if we're doing $700 a month, that can grow to kind of a value of a property, albeit in a long time, kind of 20, 23 years, but you've then got more diversification. And to my point earlier, if we need 100 grand, we can sell 100 grand of this. If we've got only properties and we need 100 grand, we need to sell a whole property. So it just gives you more flexibility. So we're very much advocates of having both if we can. So property that you live in, ideally then an investment property or two, but then also not neglecting kind of the share market as well, because it does provide diversification in the main.
Yeah, and that just goes to show that, yeah, putting in $700 a month for 23 years turns into $500,000 as well. Okay, final slide. Okay, so things to sort of take home from today, which we've largely sort of talked about. So making sure, which most of you were property owners by the sounds of it, that you've got a competitive interest rate. So potentially they're going up next week, by the way, in which case this slide will be irrelevant. However, sort of high fives to low sixes is what you should roughly be paying, depending on your situation and loan to value ratio and stuff like that. But that's sort of the ballpark. So if you're not paying that or you're paying well above that, potentially have a chat to your mortgage broker or have a chat to your bank. Do you have a plan in place for your next property? So again, if property is something that interests you and you want to build out your portfolio and stuff like that, it's making sure you are always thinking about that next move, because property is large amounts of money each time, so that needs to be executed as perfectly as possible. Review the super. So as we said, check the fees, make sure you've got a beneficiary nominated that is valid, and make sure your investment option is appropriate for your current stage of life or your current level of risk that you want to have. Insurance, so make sure that if you do need personal insurance, you have the correct amount in place. And as Scott was saying as well, make sure that if you don't need it, you're not paying for it as well, because that's just a waste of money. Do you have a plan in place to build passive income outside of super and outside of your home? So as we sort of just showed you there, from a small amount of money, you can create a passive income which will allow semi-retirement or early retirement. And we haven't talked about this too much, but we did kind of touch on it throughout the presentation, is do you make sure you have a will in place and it's up to date as well, because that's something that most people haven't done, or it's very, very old if they have.
And just with the mortgage conversation, just to close off on this, there's no harm in just giving your bank a call and asking for a discount, because 9 times out of the 10 they will give you one if they haven't already. So just making a call, and they should be able to shave kind of 0.1%, 0.2% off, which again, every little bit helps in this environment.
Cool. All right. So we will throw it out to questions if you do have any. We know we're standing between you guys and a few bin tanks, so I'll finish this up very quickly. So yeah, my name was Alex. This is Scott. We're from Everest Wealth. We are financial advisors. We do help people Australia-wide as well. We did hand out a feedback form there as well, so we'd really appreciate your feedback. If there's a way that we can improve the presentation, that would be awesome. Likewise, within our company, we do offer a free 15-minute call as well. So if you want to do that, we can have a bit more of a chat about your own personal situation and whether we could potentially help and add some value to it. And finally, we will be on tomorrow morning as well. I know some of you guys are going on tours and stuff like that, but for those of you that aren't and you want to hang around for a more intermediate session, in which we'll look at self-managed super funds, debt recycling, retirement, thank you, and more in-depth stuff around using equity to purchase future properties and stuff like that. We'll be discussing that tomorrow morning too.
Is there any last questions that anyone has before we close off? All good. Well, thanks for staying back, guys. We really appreciate it, and hope you enjoy the rest of the conference.